this picture, which shows how many of you must have felt when going in to break bad news to a family who are looking terrified. And it can be pretty hard for us too, can't it? Breaking bad news is traumatic for patients, families, and professional staff. It needs careful planning and execution. Just as we wouldn't carry out major surgery without having a careful plan and an operating theatre and doing it in the right place in the right way. But time and again you meet consultants. I remember one lady telling me how she'd been told her husband was dying by the consultant who happened to meet her in the main hospital corridor. And in front of all the people who are walking up and down the corridor, he says, "Oh, we got your husband's biopsy back." He looked at his watch. He was obviously busy, indicating to him he hadn't got much time. And he said, "I'm terribly sorry, I'm afraid the cancer's come back," and left her. And, that is not the way to break bad news. This woman 2 years later was still furiously angry with that. By the same token, people remember in detail everything that happened at such times. If you get it right, they'll be grateful to you forever. That becomes part of their memory, of that kind doctor who sat down with me and held my hand, and maybe even shed a tear too, showing that we care. It's interesting how I've never heard a doctor being criticised for crying. I've often heard them criticised for not communicating or from being distant. But as long as it's your shoulder that's being cried on, it's all right. When meeting a family, it often helps us and them if more than one member of the team's present. In a way, it's not a bad idea to bring your family to meet their family. And this is a good way of training your juniors. Rather than feeling you have to do it yourself in this sort of confidential setting, bringing someone with you helps you to feel more relaxed. It helps them to feel more relaxed and may actually help to create that relationship with the team. People feel safest at home. So if you can't choose a home, at least a home-like environment. So many hospitals are terribly impressive but mechanistic. Spend time on introductions, finding out what people already know. Time and again, you go in thinking you're going to break bad news when they already know it. They've put 2 and 2 together and made 4. All you have to do is to confirm what they already know and maybe clarify a few points, ask a few questions. Other times they've got it entirely wrong and you may need to put them right. Invite questions. I remember one lady saying to me, "You're the first doctor with this illness to invite questions." She'd noticed that with this kind of illness, doctors didn't invite questions. And if the doctors don't invite questions, it's obviously because they don't want to have to give answers. And if the doctors are frightened of giving answers, how much more frightening must that be for the patients? They notice what you don't say as well as what you do say. So, invite questions. People have a right to the truth, but the truth can be brutal. So try to give people time and try to deliver the information in bite-sized chunks. You don't have to tell it all at once. Take one step at a time, let them digest it, come back perhaps the next day to take another step. That's not dissection, it's just recognizing people's emotional needs. Ensuring that those who need it receive continuing support. Don't go away and leaving them up. One of the commonest criticisms that nurses make of doctors is that we leave them to clear up their mess, the emotional messes that we've created. And I don't think we should do that. Be prepared to come back, to answer further questions, repeat the message, and move to the next level of understanding. Support anticipatory grief. Don't make people feel they're letting the side down if they cry. Some family members may be more prepared for a death than others, and they may need extra time. I remember one young man, he was, I suppose about 21, 22. He was the husband of one of our social workers at the London hospital. And she'd asked me to visit the home where he was dying. He said, I'm a bit worried about my family. I said, really? He said, I had this interesting dream last night. He said, I was dreaming, I was floating outside my body, but my family was sitting round the bedside and they had all these strings attached to my limbs. That's my representation of this. And they were trying to pull me back down into the bed. And I said, now that's a very interesting dream, isn't it? I said, can I tell your family about that? He said, I'd be grateful if you would. So I sat down with his wife, the social worker, and his mum and dad, and the two neighbours who were helping in the caring. And I just told them the dream. And the mother immediately burst into tears. And she said, no, I can't let him go, I can't let him go. And the social worker friend put her arm round her mother-in-law and said, look, my dear, I'm afraid we've got to. We don't really have an alternative here. He's going to die. You know, this is his wish, that we will somehow find some way of letting go of him. And they talked and cried and shared a lot over the next half hour. And then it was the mother who said, look, we've got to go and talk to him about this, haven't we? And they went in to the son and, in a sense, gave him permission to die, which I thought was fascinating. And he died very peacefully 2 days later. But this is what I mean by family care and supporting the family, helping them to communicate, and in doing so to begin to come to terms before the bereavement with the thing that's going to happen anyway. Remember, our opportunities to assess bereavement risk. Some more interesting work from Australia, from Kassane and Block, who wrote a book called Family Focused Grief Therapy, which I'll say a little bit more about. But before I do that, I just want to talk a bit about genograms. As far as I'm concerned, genograms are more important than stethoscopes. They're the one way you have of finding out about the family, who exists, where might the problems be. Everybody needs to know how to read and interpret genograms. I'm sure you'll all have your own way of doing them. This is the one that is perhaps fairly widely adopted. In this one you can see the patient is John Smith, age 32. His wife, Winnie, is a twin with Gwen, whose marriage has recently broken up, with double line. Her mother died of cancer in 1998, not so long ago. Her father survives. Her husband has a brother who is living with a woman to whom he's very attached, but he's not married, and he has two parents. And the two of them have two children, Dawn and Fred, aged 4 and 18 months. Between Dawn's birth and Fred's birth, they had a miscarriage. Now, immediately looking at that, it begins to raise some questions in your mind. The mother's death from cancer. If John's got cancer, is that going to influence the way they view cancer? It'd be worth spending a few minutes with Winnie finding out how she views her mother's cancer. Was that an agonizing death that's left her terrified about the way her husband's going to go? Or was it a very peaceful death? These kinds of questions. How's her father coping without mother? Is he able to support her, or is he himself so needy that she finds herself having to support him? And what about Gwen, the breakup of her marriage? Is she going to be any use to Winnie? Or is she so broken up by what's happened that she needs support? These are sort of questions which are going to be quite important for Winnie and may influence the extent to which she's able to give adequate parenting to her two children, Fred and Dawn. That miscarriage, did that frighten her and make her particularly overprotective of Fred when he was born? Questions which you can soon find out about, but by drawing the genogram you begin to get some ideas of who's there and who might be of help. If she has a good relationship with her husband and his parents, maybe they can be of some support to her and to the kids, their grandchildren. All of this helps to build up in your mind the family picture and the attachments that exist and the kind of problems that may begin to arise. And once you start, while you're drawing this, you'll often find people wanting to tell you about their worries and telling you about, I'm very worried about Gwen because when her marriage broke up she attempted suicide or whatever. So you get a picture. Gisèle and Bloch, family-focused grief therapy. 6 to 8 sessions starting before the patient's death and continuing afterwards. They work in a hospice-type setting using very much a family orientation, seeing the family as the unit of care. They use genograms, which they develop in various ways. The genograms are a fairly flexible instrument, followed by focused intervention sessions, consolidation and termination sessions. I don't have time to go in detail into the means by which they develop their family-focused grief therapy. But I do think it's worth reminding you about a random allocation study who showed very clearly that people with supportive families don't actually need family-focused group therapy. People who are good at resolving conflict seem to do it pretty well, seem to do well without family-focused group therapy. There are 2 groups that he describes as the intermediate and sullen groups. Sullen groups, there's a fair amount of conflict going on, but it's fairly quiet, it's not too overt, and it doesn't include the doctors. And they do pretty well with family-focused group therapy. But the hostile group, who don't really collaborate with the family-focused group therapy, didn't do well and needed referral for individual therapy. So I'll give you just an example of one kind of approach using a family focus, which is sufficiently unusual to be worthy of special note. Coming on to place of death. Although most people say they'd rather die at home, this can place a great burden on the family. And as I said just now, home can be the best place or the worst place to die. An interesting study in showing that among spouses of patients dying in a hospice, there was a lower mortality rate than people dying in other circumstances of care, suggesting that the support that they get in preparing themselves for bereavement may be a factor in reducing their death rate. Fascinating study, worthy of replication and further investigation. It's a fairly recent one. As I said just now, the family remember the death in great detail, and staff who show that they care soften the blow. There's no need to hide our own sadness. And remember to treat the dead person's body with gentleness and respect, because from the family's point of view, they're still to some extent alive. It takes time to make real the fact of death. You may know intellectually that that person is not the person you loved, but it still feels as if it is. And that means that we have to reflect that awareness. When they view the dead person, let them stay as long as they like. It's a good idea to warn people so they don't get any shock that the body will be very cold. Nurses at St Christopher's Hospice, for instance, are trained to comb the patient's hair, showing it's all right to touch, but say he'll feel very cold. So when the family do reach out to kiss him, they don't suddenly sit back with the shock of an ice cold body. The day after death meeting, people come back. What they usually get is a plastic bag with the dead person's belongings and a death certificate. What they need at that time is very much more than that, an opportunity to talk to the staff who cared for that person, ask further questions. Could we have done anything more? Begin to get their heads around the reality of the death. Assess their need for further support using the kind of risk assessment I've talked about, particularly important if the death was not expected.